Thank you for inviting me for this session to talk about these two vaccine preventable diseases, because if we will forget about them and we neglect them, these diseases can lead to outbreaks, and it is going to be catastrophic during this time that we are all hurdling with COVID-19. Again, I'm Dr. Sally Jean Velasco Aro. This is the outline of my discussion for this afternoon. So when we are faced with a patient that comes to us in the ER or in the clinics presenting with rash, what are we thinking of? So rash may be a hallmark of a disease, or it can be very non-specific. It can be benign. But the rash is also an important clue to different etiologies of illnesses. That is why it is very important, it's critical for you to be able to come up with differential diagnosis based on the presentation of the rash, along with the other clinical symptoms and manifestations of the patients. Recognition is key for you to be able to make a good diagnosis and for you to be able to institute early and appropriate treatment, as well as infection control. So remember that large number of infectious agents can manifest as cutaneous lesions. So let us begin our discussion with measles. The measles virus, it's a paramyxovirus of the genus morbillivirus. Remember that there's only one antigenic type of measles virus. The reference to measles can be found from early as the 7th century, but there's a doctor during the 10th century which described measles as more to be dreaded than the smallpox, and this is by a Persian physician named Rhasis. Before a vaccine was available, infection with measles virus was nearly universal during childhood, and more than 90% of persons were immune due to past infection by age 15 years. Let us take a look at the clinical features of measles. The incubation period is usually 10 to 12 days with a prodrome of 2 to 4 days. Here, you can see that stepwise or ladder-like increase in fever. So usually it can range from 39 to 40 degrees Celsius, which is accompanied by your 3 C's, your cough, your coryza or your cold, and your conjunctivitis. 1 to 2 days before the appearance of the rash, you will be able to appreciate Koplik spots. These are bluish-white punctate lesions over a reddish background in your buccal mucosa. Many of us are not able to appreciate Koplik spots. Why is this so? Because the parents or caregivers would usually bring their children when the rashes would appear, and Koplik spots usually are no longer visible after the first or second day of the rash. The rashes begin at the hairline. It can last 5 to 6 days, and then it proceeds downward and outward to the hand and feet. It actually blanches upon fingertip pressure, and then by 3 to 4 days, they will no longer uh, blanch with pressure, and the lesions peel off in scales, especially in more severely involved areas. The rash then fades. We call it brawny desquamation in the same order that it appears, so from the head to the extremities. How does measles spread? So it is by coughing and sneezing, or close personal contact or direct contact with a person who's with infected nasal or throat secretions. And 90% are not immune, can become infected, and infected people can spread the virus 4 days before through 4 days after the rash appears. And important to take note also is that measles virus can live up to 2 hours in airspace. They remain suspended in the air after an infected person leaves the area. So see how contagious it is. So when you compare it with the coronavirus, which has an R naught of 1.4 to, like, at present it's around 3.9. Your measles virus has an R naught of 12 to 18, and by far the highest known among humankind. So indeed, it is one of the world's most contagious diseases. to further understand the R naught, so back in the days before the vaccine was widely used, it was estimated that one child with measles would infect between 12 and 18 other children on the average. So what is it about measles that makes it an effective spreader? You don't have to be exposed to a lot of the virus to become infected. You only need to have a small infectious dose. And people who are infected emit a lot of the viruses that when they cough or when they exhale. Measles is really dangerous. It can be serious. It can lead to complications, the more common of which is otitis media. But the more common cause of death would be from measles pneumonia. Who are likely to suffer severe complications from measles? It is estimated that more than 380 can die from measles complications. So that's around 16 deaths every hour. And complications of measles are most common among children aged 5 or the adults, and also with malnutrition and vitamin A deficiency and weak immune system. Speaking of vitamin A deficiency, in a study which looked into the levels of vitamin A among patients with measles, they found out that the vitamin A level is really low among these children. And children with low levels of vitamin A are more likely to have fever at temperature 40 or higher. And the fever is also more persistent, 7 days or higher. And these children are more likely to be hospitalized with low vitamin A levels also. They had lower measles specific antibody levels. Measles is diagnosed clinically. However, laboratory diagnosis may be useful for possible atypical measles, for unexplained pneumonia or encephalitis in immunocompromised patients, and in areas where clinicians may be unfamiliar or unsure of the clinical constellations of measles. So there are actually no specific treatment. So treatment of measles are essentially supportive, and as mentioned also, because there is an associated vitamin A deficiency or a low level of vitamins among patients with measles, it's recommended to supplement with vitamin A. So the therapeutic dose of the vitamin A of measles should be started as soon as diagnosis is made, regardless of the last dose of vitamin A or when the last dose of the vitamin A was given. So supplementation is given for 2 doses, 24 hours apart, as follows. You can give antibiotics for complications. So let's say, for example, if you're considering a possible secondary bacterial pneumonia, you can give antibiotics. Measles has been shown to be susceptible to ribavirin, but this is in vitro. And there are no controlled trials conducted for the use of ribavirin for measles. Thus, this is not recommended. What about prevention? So this is where we have a big responsibility. For the prevention of measles, we need to isolate the patient from 7th day after exposure until 5 days of the appearance of the rash. Post-exposure prophylaxis should be considered in unvaccinated contacts. So post-exposure prophylaxis can be done with measles vaccine within 72 hours or 3 days after exposure to measles. And this can be given to infants, children, adolescents, and adults, because this vaccine may offer protection or modify the clinical course of measles. And this may also provide protection for future exposures. You can also give human immunoglobulin to prevent or modify measles in susceptible individuals if you administer it within 6 days of exposure. So let's focus on the Philippine situation with the cases of measles and the vaccine coverage. Note that measles cases began to increase in the early part of 2018 in an outbreak. The red line graph shows you the increasing COVID-19 cases in 2020, while measles cases started to stabilize. But should we be happy with this situation and be complacent? Um, Even before the strike of the pandemic, we are having challenges with vaccine coverage, especially to the most vulnerable but eligible for vaccination. See here the graph below. During the outbreak, the age group most affected were the 1 to 4 years old, and majority were not vaccinated. If you want to eliminate measles, it is not like the other diseases. We need higher levels of population immunity in order to interrupt the transmission of the virus. So an immunization coverage of 95% among all children is needed for a community to be fully protected against measles. And these are some of the reasons why there's non-vaccination of measles among those patients who had confirmed measles. So one is that most cases, those patients who developed measles were not eligible for vaccination. The second reason was that the mother, the caregiver, was busy to bring the child to the center for vaccination, or the child was sick and they missed the opportunity to be vaccinated. Some of the parents fear side effects or potential side effects from vaccination, or simply they forgot totally the schedule, and others reported that there was difficulty in accessing health services, and a small proportion were saying that vaccination is against their belief. This is really quite problematic because, as you know, measles is so contagious, and with low immunization coverage, there's likelihood of measles outbreak to increase. So, problema na natin po siya dati, mas naging doble, triple ang problema ngayong meron tayong pandemya. So, fewer childhood vaccines have been given during the COVID-19 pandemic. Hindi lang naman problema ang measles, pero yung ibang mga vaccine preventable diseases, problema din natin. In fact, it has been said that 2 million Filipino children may missed out their vaccinations in 2020, and it still continued to increase now in 2021 amidst the COVID-19 pandemic. Why is this so? So, with the continuous pandemic and the lockdown, the ECQ, there's an increased risk of measles, and an outbreak is bound to happen. Why? Because again, we said that there's very low immunization coverage because people are either unable to access the vaccine. So aside from those that I've mentioned previously, so now they are unable to leave their home because of the lockdowns. So there's a scarcity of transportation. Also, there's a big impact in the economy. There's restriction of movements, or simply the parents are afraid of bringing their children to the hospital because of possible exposure to people with COVID-19. And aside from that, many of the healthcare workers are also unavailable because of the restriction to travel, or they are deployed to COVID response duties, as well as lack of protective equipment. And so we are reminded to continue to educate our parents, our caregivers, and routine measles vaccination for children combined with mass immunization campaigns in countries with low routine coverage, like in the Philippines, are key public strategies or key public health strategies in order to decrease global double death. The childhood immunization calendar of PIDS-P, PPS, and PFV recommends measles vaccination at 9 months of age, another measles containing vaccine starting from 1 year of age, and then the third dose at least 4 weeks apart from the last dose. Measles vaccine can also be given as early as 6 months during outbreaks. If monovalent measles vaccine are not available, as you can see, your measles vaccine can come in the form of monovalent measles vaccine or combination vaccines, your measles, mumps, rubella, or your measles, mumps, rubella, varicella vaccine. So if you don't have your monovalent measles vaccine, you can give your MR or your MMR vaccine for those patients less than 12 months of age, with an additional of 2 more doses of MMR for children 12 months or more, at least 4 weeks apart. You can also make use of higher combination vaccines, your MMRV, as an alternative. You can give it at a minimum age of 12 months and a maximum age of 12 years. The minimum interval between doses, so you also need 2 doses of your MMRV, is 3 months, but 4 weeks is already considered valid. Now, moving on, the varicella. So varicella, the etiologic agent is your varicella-zoster-virus. So it's called varicella-zoster-virus, or chickenpox. The humans are the only reservoir of the infection. We know that the primary infection is the chickenpox, and reactivation is possible in the form of shingles. Transmission from patients with varicella and the herpes zoster primarily is via the respiratory route. The incubation period is usually 10 to 21 days, and varicella is also highly infectious like your measles. Here are the clinical features of varicella. For immunocompromised patients, this varicella or chickenpox can be severe. If you look at this example, the rashes look different. It looks more toxic looking, no, in patients with leukemia, and this can happen in 50% of leukemic patients. While some others, they would have asymptomatic course. Around 5% would have asymptomatic course. So this is the typical appearance of your chicken pox, the lesions in chicken pox. No? So blister formation, you'd also be able to appreciate macular rashes. So at the same time with the blister formation. Severe varicella complications are also possible. You can, especially among the immunocompromised and those who are older than 15 years of age, those who are younger than 1 year of age, those who are newborn, to women who developed varicella during pregnancy. So they can develop pneumonia or secondary bacterial infection. This is an example of a patient with congenital varicella syndrome and a patient with disseminated varicella and a child with leukemia. So more common at extreme of ages, and again, persons with cellular immune deficiencies. Common causes of death are from pneumonia, the encephalitis, or the secondary bacterial infections, or bleeding complications. Just like measles, diagnosis is mainly clinical. However, laboratory testing is recommended for, let's say, for example, surveillance purposes, to confirm suspected cases of varicella, confirm varicella as a cause of outbreak, or confirm varicella in severe cases or hospitalizations or deaths or unusual cases, or determine susceptibility to varicella, or determine if suspected vaccine-related adverse events were caused by the vaccine strain. So we can make use of these different laboratory diagnostics, such as your PCR and your serologic immunoassays. So now that we are in the pandemic, should we be comfortable and happy that we will be able to decline or decrease the number of cases of varicella? At first, yes, we are thinking that because children are not going to school, there's no way that they're going to be exposed to other people um, who might have contracted the varicella. So we are kampante. But in this study, um, during the pandemic, they noted that because children are being taken care of by other family members who are also at risk of developing a reactivation or developing a reactivation of your varicella, these kids, so the first is a 13-year-old child who developed blisters, and she was living with her grandmother who was diagnosed with herpes zoster. And the other one is a 3-year-old child, and his sister who also developed the lesions on the trunk no? So after being exposed to their grandfather, so three generations of their family, the children, the parents, the grandparents, lived in the same residence. And the diagnosis of varicella was based on the typical clinical manifestations. So different from previous literatures with the development of varicella in children following exposure with herpes infection, the varicella-zoster-virus transmission source was clearly single as family elders with herpes zoster in the above cases. And three varicella children completely stay, nasa bahay lang po sila. So during during this whole pandemic, and this is really shows us direct clinical evidence of varicella zoster transmission from herpes zoster patients and inducing primary varicella. So what is more alarming is that the patient may not only be suffering from varicella, but at the same time, COVID-19. So, hindi naman po masyadong madami yung reported cases. But this is one case report of a 12-year-old who tested positive IgM serologically for varicella and also RT-PCR positive for COVID-19. And this patient developed severe pneumonia. So we are more afraid about the complications. So COVID-19 in itself is problematic. Chickenpox complications is also problematic. So it's not a good combination. So we are expecting more serious complications from patients developing both of these diseases. So how do we manage varicella? So mainly just like measles, it is supportive, but we can make use of antiviral therapy. But we have to it is determined by the host, if it's if the patient is immunocompromised, the extent of the infection, and the initial response to therapy, because the antiviral drugs have limited window of opportunity to affect the outcome of varicella zoster. And it has been said that when you administer within 24 hours of onset of the rash, it will only result in modest decrease in the symptoms. So antivirals can be recommended for those patients who are at risk of developing moderate to severe varicella, such as those older than 12 years of age, those with chronic or pulmonary disorders, those who are on steroids, and they can also be used for secondary household cases wherein it has been said that the disease is usually more severe than the primary cases. So aside from management of these patients, it's important to observe airborne precautions for patients with varicella until all lesions are crested, typically 5 days after the onset of the rash, but a week or longer in immunocompromised patients. We are more after the prevention. So we need post-exposure prophylaxis, especially for immunocompromised children and pregnant women, as well as newborns exposed to maternal varicella within 96 hours after exposure. We don't have varicella zoster immunoglobulin readily available, and in that case, we can give IVIG. Varicella vaccine for healthy children is also recommended to be given 3 to 5 days after exposure. So vaccination against varicella is also part of the childhood immunization calendar of the PPS, PSP, and PFV. It is given as a two-dose regimen given at as early as 12 months of life, and the second dose can be given at 4 to 6 years of age, but it can be given earlier at an interval of 3 months from the first dose. However, if the second dose was given at 4 weeks from the first dose, it can already be considered valid. For those children more than 13 years of age, it is also recommended to give 2 doses with a minimum of 4 weeks. Last look. So I'd like to remind you again and again that outbreaks are inevitable as childhood vaccination decreases. So that's why we have I keep on mentioning this, it's our responsibility now. See here on the left, this tells us how many children will die from COVID-19 due to vaccination programs continuing. And on the right side, you will see here the number of children who will die from vaccine-preventable diseases when vaccination programs are being suspended or canceled. So marami pa rin pong mamamatay from vaccine-preventable diseases kung ititigil natin or hindi natin ipagpapatuloy ang pagbabakuna sa ating mga pasyente. What we can do, we have to continue educating our parents, our caregivers, and tell them about the importance of vaccination, correcting their misconception, and reassure them of that vaccines are effective and safe. Provide them with clear recommendations. You also have to listen to them, uh, make them understand the about the consequences if their children are not vaccinated. You also have to understand their concerns or why they're hesitant of having their children vaccinated. We need to maximize the opportunity for vaccination, like giving simultaneous vaccines or several vaccines at one visit, and following appropriate intervals, or making use of combination vaccines. We also offer vaccines to individuals who do not have any proof of vaccination but are at risk of infection. We have to support programs of the government and encourage patients to participate during the supplemental immunization activity, especially that of measles. I encourage you to participate in disease surveillance and reporting, and not just for the diseases but also adverse events following immunization. And lastly, to walk the talk. We ourselves should advocate vaccination and have ourselves vaccinated with the recommended vaccines for age. And with that, I'd like to end with these key messages. The world's battling with the new coronavirus. While it's far from over, it could be made exponentially worse if outbreaks of vaccine preventable illnesses are not addressed quickly and efficiently. Measles and varicella are more communicable than COVID-19. Outbreaks are inevitable as childhood vaccine rates decrease. Immunization programs and schedules require our immediate and urgent attention, and we should continue to work together in saving lives. These are the references I used in my discussion. I'd like to thank everyone for your kind attention, for listening. Let us all keep safe, and good afternoon.